where you weren't sure what was going to happen when you couldn't make the decisions for yourself? Like, what if something happened? Let's say there's a car accident. You're alive, but you can't tell somebody what you want. Let's talk about, that could happen to any of us at any time. Or what if something, say, we weren't able to remember things, started having challenges with our memory, with our ability to process different tasks. Maybe we started having some dementia. There's some really scary things that can happen there. And we're trying to figure out how do we make our wishes known if something like that were to happen. This is important for everybody, myself, for you, for even our kids to a certain extent, depending how old they are, and then what we can do for them as well. But before I get into it, I want to introduce somebody. This is Marietta. She is actually my grandmother-in-law, my wife's grandmother, and she was getting towards the end of her life. And over the last 10 years, there were some small things. She started kind of forgetting things. She started losing track of things. She decided she wasn't going to drive anymore. She started having some signs that were really early dementia. As a provider, I was able to see that as it was progressing, but a lot of the family didn't see it. And it can be really challenging. Now, there's a bunch of ranges of dementia. There's early, middle, and late is generally how we break it down. Early dementia isn't that big of a deal. There's no real impact on your life. But it's like this, it can be like a little more than the small things of just forgetting where your keys are or getting lost, but it starting to be more impactful. As we get into the middle stages of dementia, there's some challenges where we start having a hard time processing more complex thoughts. For example, what might happen if I didn't treat this urinary tract infection? Or if I didn't have this procedure done, what would happen? Or what did I want when I knew everything was going on? What would I wanted then, and do I understand where I am today? And then there's late stage dementia where people actually get into a phase where it's hard to eat, it's hard to remember to do some of the basic phases of life. And this is really scary for all of us, especially family or people that have dementia in their history or their family history, and trying to catch this and pay attention to it. The reason I bring it up is there comes a point when are you not able to recognize the impact of these pieces, right? And for her, there's a lot of these pieces to where she actually ended up needing to go to a nursing home, and it actually was really good for her. It was able to help her with her medication, was able to help put her in a spot where she was safe, but she also got to make a lot of decisions, and she got to do a lot of things and remain really independent. However, as the disease progressed, she did move into that late stage. And this comes to a point of where I want to discuss something called capacity. And capacity is that ability to recognize the consequences of our actions. Like we look at a 2-year-old, they don't have the capacity to understand what happens when they climb 10 feet up on the playground, right? They don't understand the consequence of there, and when they fall, they can get really hurt. That's why parents are helicoptering around them on the playground. As we get a little bit older, we start understanding the consequences of our actions. When we get to a spot where we're unable to understand those consequences, we no longer have capacity. And the real reason I bring that up is then who makes those decisions? If we aren't in a spot to take care of ourselves, to where we can communicate that with somebody, who is going to be that decision maker for us? And that's what I really want to talk about today, because that's really an important piece of that puzzle, because as we're moving forward in our lives, there will come a point when we may not be able to make that decision. So I kind of like to break it down for everybody. Idaho has a fairly straightforward breakdown of who has capacity if there's not somebody assigned. So the first person that has capacity would be a court-appointed guardian. They're going to be over, if you were at a spot where it's a court-appointed guardian, they trump everyone else, because there was a spot where anyone else in this list was not able to make those decisions. Ideally, no one needs to get there, because the first person that we'd prefer to have capacity would be somebody that we assigned ourselves. So it might be my best friend. I've had really long discussions with him about what I want at the end of my life, or if something were to happen. And I would appoint somebody to be my medical power of attorney. Right now, that's my wife, and she would make those decisions for me. But there's paperwork for that, and we're going to talk about that as well. But then the next person, by default, if we don't have a medical power of attorney that assigns who makes those decisions, it's your spouse. And even if somebody were estranged from their spouse but did not have a formal divorce, their spouse would still be the formal decision maker. So paperwork is important. After that, The next person is going to be your children, your adult children, so over the age of 18. Now, they also fall at the same level as your parents, which could get into a really awkward situation if you're in your 50s or 40s, because your adult children and your parents might have drastically different opinions if people aren't on the same page. And that can really get to be a sticking point. After that, anyone in the family who says, I know this person, would be the medical power of, or would be the decision maker if there was not somebody else appointed. And then finally, if there was a friend who said, I know this person, they've told me what I want, what they want, they kind of become the default decision maker if there's nobody else available to have that conversation. And in a worst case scenario, the doctor. And the doctor is going to do everything we can possible to preserve life, and up till the point of futility. And if somebody hasn't made that decision, there's nobody else available to have that discussion, and we haven't had that conversation, we're going to fall into that window. We're going to do the best that we can to help somebody stay alive for as long as possible, which often means life support, chest compressions, electric shock, all of those aggressive interventions to try to kickstart somebody's heart and keep it going. So the reason I bring this up is that it is really valuable to have that discussion with somebody. And if you can, one, talk to or do the paperwork, assign a medical power of attorney, and we're actually going to, when we break out into some groups, we're going to talk about that specifically and how to have that conversation. So the next spot, if somebody was in the ICU and we're trying to take care of them, and there's not a medical power of attorney, or maybe there is, there can be some significant challenges that can be addressed with the family to prepare everybody for that. Now, these aren't easy talks. These are hard talks to say, hey, I know I'm going to die. Because life's a terminal experience. We all are going to go on to whatever's next. And that point's going to come. And sometimes people are afraid to recognize that. And talking to our family is really important to have that conversation, to tell them what we would want. Because if you can get everybody on the same page, even if the family member's in Europe, right, and if they're going to be coming in, if there's something that happened, having everyone on the same page is really important. Because when we're in that conversation, if there are people that are going different directions, I've seen a lot of family strife happen in these kind of conversations. Other pieces are, if it wasn't written down, it can be very hard for the family to say, this is what I think they would have wanted, right? And trying to put that on somebody then makes them make the decision, as opposed to honoring somebody's decision, which is much easier to do, because it's really hard for somebody to come to that point to realize that we need to actually withdraw care, that it's time to let somebody pass. And that burden on somebody is very painful. And I'm all of y'all have lost people before, and you've probably been around that experience, and it's hard. And if you can help alleviate that burden by having that discussion in advance, it is so valuable, because then they're honoring that person and giving them that experience. So other things that would be worth considering, so for like Loretta with her dementia, as she got farther along, that have been really important things to discuss that she didn't really talk about, would be, would she want a feeding tube? If she couldn't feed herself, would she want a feeding tube? Maybe, maybe not. Would she want an IV fluids? Would she want antibiotics, right? If it was something that would get better, do we want to treat it? If she's kind of having a hard time remembering to eat, and she has a disease, like an illness, and she's not uncomfortable, where do we want to go, right? Really important and in-depth questions and hard. Hi, guys. Sorry, y'all are jumping into some hard pieces. You're good. So having that conversation can be really important. And for that, having that medical power of attorney and assigning that person is very valuable, and having that very in-depth conversation. And I would even argue having one medical power and a pinch hitter, having somebody else in case at 2 a.m. we can't get a hold of that person that would be your medical power of attorney, and letting somebody else also in on that conversation. And ideally, everybody in the family that's going to be in that window. It's really important. So as she progressed, this is her with my kids, she did get to a spot where she stopped eating. But the family had all worked together, and they kind of talked about what the progression was going to be. They read some different books. They understood the disease process of dementia. And she was actually able to pass with all of her family there, in her own bed, in the nursing facility. And it actually turned out to be a really good experience for bringing her children together. And they were able to tell stories, able to laugh, and it was a really therapeutic experience for the family. So that's one of the ways that this can go. Now, I am going to talk about somebody else, and this is 𝐀 Montgomery. She's an 84-year-old female. She has a myriad of health issues, breathing being one of them, and she ended up in the hospital. And 𝐀 had been going in and out of the hospital a lot. And over the last 2-3 years, she's probably been in the hospital 10 times. So it felt like every other month she was there. So she had a hard time kind of figuring out I'm just going to the hospital. I'll be out in a couple days and I'll be fine. Well, this time she ended up in the ICU. And she was having to have some breathing assistance. And when she was into this spot, she actually got to be very confused and was actually starting, medically it doesn't matter, but she started becoming confused because of the hard time with her breathing. It was becoming a problem. So now her family was in this spot. Interestingly, she had revoked her power of attorney and her medical power of attorney about 4 months before this episode, which is an interesting piece. If you have a power of attorney or a medical power of attorney, it is only valid as long as you say it's valid. If you rip it in half, it's no longer valid. However, at this spot, even though that she disposed of her power of attorney, she had not, or medical power of attorney and her power of attorney, disposed of her medical power of attorney, it defaulted to who would be the next decision maker, who was her prior medical power of attorney. And it was her children between the two of them. And they'd had that conversation many times that she didn't want to be on a ventilator, right? And that was her hard line. So what happens when you're in the ICU and somebody's super sick like this is a scary moment. The ICU doc is there, and oftentimes the family member's there. There's usually a nurse around, but it'll come down to the family to make decisions. And 𝐀 was not in a spot where she could. So in order to prepare for that, there's a couple different things that we can do. One of the things that you can do is have a very specific list of all the different interventions that you want to have done. And that's what we're going to work on after this talk when we break out into small groups. Another piece is before you go into that meeting, if you're representing the person who's not able to make the decisions for themselves, is talk to the other people that would want to be there and have a consensus. Discuss what you would want to do. And even bring them in if they're not able to be there on FaceTime or on speakerphone, and having everybody on the same place. And that can really help a lot, especially as a disease progresses towards the end. And as everybody understands where we are now and what the likely trajectory might be and what our plans would be. During these family meetings, it'll also be the discussion on what would she have want done. And this is where that discussion with your family members is incredibly important because you're able to represent them. And there's been so many times where I've been there and the family hadn't had that discussion and you don't really know what they would have wanted to do. So then you try to extrapolate and you ask for stories, and you ask for like what kind of situation they'd want to be in, what challenges they'd had, where they wanted to go. And you try to have the family come together with a decision. The medical side, we're trying to give the perspective of where we think this is going to progress. And it's very hard when somebody's very ill to tell somebody how this is going to end. So those are a couple of pieces on the different pieces. Being prepared for that family meeting is incredibly important. And I'm going to talk about a couple documents that are going to be there. This is going to be what I was talking about, having that medical power of attorney. But a living will is a little bit different. A living will is that document that actually specifically breaks down what you'd want done. Also called medical directives, healthcare proxies, advanced care, healthcare directives. Each hospital is going to have a different piece for this, or what it's called. One of the things that we can do for that is actually have a binder that has that information in it. The last talk we did, we actually talked about having a binder with all of your medical history in it, but also having your living will in it is very useful. So if you go to the hospital and you had a binder that had all of your medical story, all of your meds, that's very helpful. But then you also have the living will saying that if I was in the worst case scenario, here's what I would want done. Now, in the medical world, we do this thing when someone comes to the hospital and say, what is your code status? And I'll be honest, it's doctorese. It is unfortunately confusing because it implies so much and it embodies all of this in 3 words, right? Full code, There's 2 words. Or do not resuscitate, 3 words. Do not intubate's another 3. DNR, DNI. But there's so much power in those words, and there's so much complexity in those that I don't think it's fair to try to put that on somebody and say, what is your code status? Having a living will gives a lot more perspective of what that end of life plan would be. And that is specifically talking, if your heart was going to go into a rhythm that wasn't compatible with life, what would you want done? And that would also be incorporated into your living will. And it's really valuable. So there's a program called 5 Wishes. And I think it's a really well laid out program to understand kind of what that end of life could be, who would be the person that would help represent you, and how that would work. I have some sample copies that I'm willing to, that we're going to utilize, and when we break out in small groups, so that we can go through them, we can talk about it, and we can talk about the different phases of what somebody would like, and what we can break down in those small groups. But before we do, any questions about what we've touched on? And this is an incredibly complex topic to be like, that's why I like going into a small group. But any questions before we break out into small groups? Yes, ma'am.
Well, what's the laws of Idaho?
Great question.
Can the real estate laws of Idaho accept a person's wishes?
Yes. So if you have a living will that's signed, that is your wishes. And if that's what you would want done, yes, absolutely. As long as you have capacity, going back and you can make those decisions, we will always honor those, right? And that can be, let's just say someone has cancer, right? I don't want to be treated for cancer. Okay. Know what's going to happen, but absolutely, let's support you. Let's make sure this is, wherever this is going to end up, let's make sure we can honor your desires, right? So yes, a living will is essentially you being in the room, having that ability to have that conversation, and it would trump even your medical power of attorney within reason. Great question. Any other questions before we break into small groups?
Where did the post form come in?
Oh, great question. The post form is a form that is valid when the EMS comes to pick you up. And essentially that kind of has some living will on it as well in a very brief fashion, like I would want IV fluids or I would not. And there's a few other pieces there. But generally the post form is going to be, if EMS picks you up, it's doctor's orders on what you would want done at that window. So EMS's default, if you show up and there's not something that says DNR, DNI, do not resuscitate, do not intubate, is they will do everything possible until they bring you to the hospital, and then it will be the hospital's responsibility. So the post form's primary purpose is being that neon pink form on the refrigerator. I'm going to just show you an example because that's a great point.
In Idaho, it's mostly white, just so you know. I know it's pink, but
It's white because it's easy to print off. I highly recommend making it in a more than obnoxious color to have on your fridge. Neon orange, neon pink, pick your favorite. I like pink because it's the most visible color, period. I told the Navy they should do pink uniforms in case someone fell off the boat. They didn't like that. They went with navy blue. I don't know. So the post form is the Idaho physician orders of scope of treatment. There's a specific position on if somebody wanted to have what they'd want for their code status, either everything done or not. Then there is a second section, which is the most brief living will humanly possible, where it's talking about comfort measures, limited interventions, and aggressive interventions. And while, yes, this would technically be a living will, it leaves so much open and not ability to express yourself that I feel like this is a important piece to have as part of your care, especially if you're picked up by EMS. But having a full living will is a lot more valuable than this brief document. Yes, ma'am.
On my refrigerator in case the medics have to come into the house.
And that's exactly where it should be.
And I've also filed with the state of Idaho.
There is a place on the Idaho, what is it, Board of Health, I believe, where you can upload your post form. It will not, they won't be able to reference it if it was an emergency and they showed up. It could be referenced in a hospital. The work that it takes to find documentation that's hidden in a database, while sometimes expedient, oftentimes is not done because it is hard to do. Much more valuable to have the document in front of you in the hospital, and it's much more likely to be honored quickly.
I have a piece of neon cardstock for everyone. That would like one. So if you want to take it when you leave, you can print it on a piece of bright colored paper.
Yeah, absolutely. We can even make some copies of these.
Yeah.
When I was hospitalized, one time the nurses asked for that, and I gave that, and I said, this is what's registered with the state of Idaho. But there is a password on it,
Mhm.
so they can, and that's fine, but for immediate attention, I need medics to come to the house. Do they want to resuscitate or not? That's what's important at the time.
That's right. And the post form, they are trained to look on the fridge for the post form. And that's one of the things they're going to do as soon as someone's going to evaluate the patient and the other person's going to look at the fridge. It's one of the first things they do coming into the house. So it is actually a really valuable piece to help communicate whatever your wishes would be.
Will they, suppose I, hypothetically, I said a DNR.
Mhm.
And, you know, I just read if I had a massive heart attack or something, then I'm done.
Sure.
But, you know, I do have, you know, little heart issues, and that's not going to kill me right now, I don't think. But they will, even though I say do a DNR for some things, they will do what's necessary to keep my heart beating at the time. If, say I just had a heart attack.
Sure. See, this is where things get really tricky. And that's why I don't like code status, because it is a black and white definition. If your answer is, I want CPR for any reason, if it's heart attack or otherwise, then an out of hospital full code would be reasonable. And then in hospital could be different. And this is really hard. I'm not trying to push full code on anybody, but EMS doesn't have the ability to determine the cause of somebody's illness. Their ability is to recognize an emergent situation and respond to it. But they cannot diagnose. They can treat things, and what they do is they treat by assumption. So if they can't hear lung sounds on one side, they just throw something because they think there might be air on that side, they just treat it. And if there wasn't air, there is now. That's not their problem. They're trying to fix life-saving interventions so they can get somebody to the hospital. Let's talk more. That's a nuanced challenge. And let's talk in the smaller groups, and we can dive into it. Any other big questions? And if there's, what we'll do is we'll break into 3 groups so we can all have discussions, and then we'll come back as a main group and be able to talk about what we talked about. Yes, sir.
Just a quick question. You said that, excuse me, living will trumped pretty much everybody in the process.
Right.
So if my normal person, my spouse,
Mhm.
We both had this, we got in an accident, she was killed outright.
Okay.
I'm, about ready to drop, but a child or friend or whoever came in and said, oh no, they want to do, the living will would still trump them?
This is a hard spot
Okay.
for a couple reasons. One, the living will has to be present.
Okay.
And if you don't have it readily available, somebody that says, I know what they would want will probably trump it until there's that discussion, we find it, and we're able to say, this is what it says. In an ideal world, everyone's living will is readily available in an EMR-ish. An EMR is electronic medical record. Sometimes it's hard to find that document. Sometimes it's an old copy. Sometimes a new copy didn't get uploaded. There can be some challenges with that. Having the paper document is always more useful than something in the computer. And until that document is found and produced and saying this is what they would want, if there was somebody that was a regional representative, they would be making the decisions. That's a hard spot. And yes, that's a terrifying situation. Let's go ahead and break into 3 groups. How many do we have? We have 6, 10, 14. Tracy, do you mind taking one group?
Sure.
And then Michaela, you'll take another. We have a couple rooms here, one right here across. I heard there was a few questions on where you could get one of these packets. Anyone's welcome to my blue packets. Those are the formal ones. I just didn't purchase additional ones for the talk. If you want to get your own copy, there's 5wishes.org. And you can have a digital online copy as well that you can update. I think it's $15 and to have the digital one, or it's really inexpensive for them to mail you one also. So if you want that, I like the 5 wishes because I think it breaks it down to very specifics that provides opportunities for you to express what you would want. But there's also briefer copies of living wills as well. The 5 wishes is fairly in depth. There are a couple copies that the hospice group uses, Hospice North Idaho, over here if you want one of those take home also. You can compare them and you'll see how brief some are and how expansive obviously 5 wishes is. Would anyone be willing to share some of the ideas and things y'all talked about that you would think would be useful for the whole group?
One of the things that I brought up in our group was that if we fill out the 5 wishes, we're going to have a paper copy that's handy, but I'm also going to scan it and keep it on my phone as a PDF, so that, you know, if something happens to the paper copy or we don't have it or whatever, we would have it on the phone. And
So when you're traveling,
or, yeah, well, hopefully if we're traveling, I just take this with me, but, yeah, to have it on the phone as a backup, basically.
Or even just a car accident?
But then it was brought up too, then by, gentleman back here about having the password to get on the phone.
Right.
So somebody's gotta have that.
Yeah.
Which is your,
If your phone's password protected.
You could even share it directly with your medical power of attorney, so they'd have a copy of it and have a PDF on their phone. So if they needed to talk even via phone, they could send that in and said, hey, do you have a copy of their living will? Here it is. That's a great idea. Yes, ma'am.
Do you know if there's a DNR bracelet you can get?
So there are DNR bracelets, and I've even heard of people doing like DNR tattoos to be the most extreme situation. The post form is supposed to be that form or that expression, and having that on the fridge is probably the best option. EMS is technically supposed to do everything if they find somebody down. However, if somebody has a DNR bracelet, it's going to be a gray zone if they're going to honor it or not. It's not a doctor's order. What's nice about that pink form, that post form, is that's a doctor's order saying don't do it, as opposed to just the bracelet, which makes it a little bit trickier.
just say somebody else didn't put that rose.
And who's not to say their name is Diane Nolan Rolander, right? It could be anything. Even though it says DNR, it may not be, it's not necessarily specific enough.
It'd be a Gary Mason,
Right.
something that somebody put it on after.
Yeah, exactly. That's a rather well-prepared person, but yes. But within reason. And EMS is going to try to honor that. And also the person that's calling the ambulance is going to try to say what would be want done. But that's a hard spot.
Does anybody want a bright colored post form to put on your fridge? Okay, I'll just pass it out.
So the post form should be signed by a physician. If somebody knows what they would want and puts their information on there, wants to discuss it with me afterwards, I'm glad to put my name on it, my license on it. I will not have medical documentation on my side about it though, so. Anybody else? Anything else you want to share? Awesome. Yeah, I'll fill it out for you if you'd like me to.
And then I can fill it in.
No,
Oh, I can-
we have to fill it out together. I can't just put my name on it. We can fill it out together and have that conversation. I'm absolutely glad to have that conversation and sign it, but I cannot just blankly sign it and send it home with you.
I have
Yes,
a
ma'am.
question. And you might have mentioned this and I didn't recognize it, but who notarizes the post form?
So the post form isn't notarized.
Oh.
It's signed by a physician.
Oh,
And the living will in Idaho doesn't require a notary. I encourage it just to make it as formal a document as possible, but by default, medical providers are going to respect documentation that you bring in saying what you would want, or if somebody of your family said this is what they would want. We have to trust the family members that are helping care with that person. I've never been in a spot where I had conflicting documentation, thank goodness. Because that would be a very hard spot that the ethics committee would have to get involved in. It would be terrible. Generally, somebody doesn't try to bring in a fake documentation. And we try to honor whatever documentation we have.
It's important to have clear like that.
Yes, absolutely. And within Kootenai, there is an opportunity for you to upload it into the chart. And that's the ideal scenario, at least. So that's within our main hospital system. In the ideal scenario, we're going to review that as well. But in an emergency, sometimes it's hard to do.
So the hospital should have an NRGP.
Yes, that would be ideal. Yeah. And if those are in the same system, even better. Yes, sir.
Has made it easier if you have an advanced directive plus minus a post form. There is now a spot in our health record. It's like a big yellow box that we can just click on and it should take us right to those. So if you have them, they should be readily available.
A lot of shoulds there.
Should.
Paperwork's really nice. And especially that might be an old copy. If something changed, that's a big deal too, right? So the most up-to-date one with the most recent date will be the one that trumps it. Anything else?
The post form will take off several trips worth of magnets and things on the fridge. You have a smaller high-vis dot and have the people inside.
No, I don't. I'm sorry. Very little stamp for the doctor to sign the magnet.
Look inside.
Yeah.
Well, I will say you can put it in an envelope that's brightly colored that says POST on the outside of it. Sometimes when people live in a multi-generational household, they don't necessarily want their grandkids to see that DNR every time they go to get a snack.
Yeah.
So they have it in an envelope that's brightly colored that says POST on it. So
That's a great idea, Tracy. So our next talk that we're doing, I believe it's the last week of November.
Let me double check.
Megan's going to double check our date on it. That talk is going to have a local lawyer that helps with estate planning a little bit and real estate planning. He'll be here doing a talk as well. So if you'd like to come back and hear his perspective, he'll be able to have that talk. He'll also talk a little bit more in depth on the legalese piece, and he has some perspective on wills and that piece as well.
November 30th, communication. What happens when your paperwork isn't together? And it's at the same time, presentation from 6 to 7, and then 30-minute Q&A from 7 to 7:30 right here. And just trying to think if there's anything else with that. Oh, and we'll probably record that as well. We encourage, people to attend in person just because you get that interaction, those breakout sessions. But if you are unable, we will put it on our YouTube channel the day
Yeah.
after.
That'll actually be Brian Bean. He's the lawyer that'll be coming to talk.
Is there a previous episode in this series?
There was. Nobody showed up.
you were here.
Yeah.
However, we're talking about potentially repeating it in December to have that opportunity. So if now we have a few more people that have been present, would y'all like me to redo that talk in December? Would that be useful? It's talking about the phases of care going from clinic to ICU and hospice and how there's a lot of hiccups that can happen in that transition and what you can do to help minimize those and how to maximize it. Okay. We can pick a December date. We'll have that for the next meeting. Yeah, I'd be happy to do that.
We'll see it in the paper, right? We'll certainly gonna-
Last time when I did the press release, they gave the first press release out and then they didn't do the second, 2 and 3. But I will submit a press release for each.
Well, now we know how charming and informative you are, I'm sure the word will spread.
Yeah,
You
and
can also check our hospiceofnorthidaho.org website, and his times and dates and everything will be on there.
Yeah.
So
great. I'll hang around if anyone wants to go through the pulse form with me. Yeah. Hey, if you have a question, go ahead.
Would you have any guidance on where to get some Medicaid planning assistance and specifically in the context of IRAs and payout status and the nuances of that?
So there are several people in the area that can do Medicare and Medicaid counseling, but I don't have any specific resources.
So Sheba
There we go.
If you remember Ken from our first talk,
Yep.
he works for 𝐏𝐫𝐞, which is the state health insurance. Oh gosh, I don't know the last two acronyms, but 𝐏𝐫𝐞 is an agency that provides free counseling on Medicare and Medicaid, choosing supplemental plans, those kinds of things. So I can look up the phone number and give you the phone number if you'd like it.
If you're looking for payouts and specific pieces,
Here's how I measure, when we get down to the counting of assets, counting of income, what's exempt, what can they latch onto and run away with.
yeah, 𝐏𝐫𝐞 would be a great resource for that. Squirreling away assets, it has to be done within after 5 years.
Sure.
So, yes, that's an excellent idea to help preserve wealth. Because if somebody ends up in a situation where they're needing to utilize those assets, say for a nursing home, they will liquidate their assets first before the state picks up the bill.
And is it open enrollment coming up?
I believe it is.
November 15th, December 7th.
Yep. Great. Anything else? Oh,
There's a 1-800 number for 𝐏𝐫𝐞 for anybody who wants to write it down. You ready? It's 1-800-721-3272.
Just as a side note on that too, if you need to move assets.
Say it again.
In order to,
1-800-721-3272. Sorry, I didn't mean it.
Sorry, go ahead, Chris.
if one needs to move assets in order to qualify for Medicaid, you can do that through paying for your own cremation or burial on those. That won't count toward your assets. So that you can qualify.
So that's the phone number for 𝐏𝐫𝐞. There we go.
If anybody has any specific questions about palliative care, hospice, or the Steinmiller House, Tracy is here as well to fill you in. Just gotta put that plug in there.
All right. Without further ado, though, thank you very much for coming, guys. I really appreciate
See
your
you
time
at the next
tonight.
one.
Yeah. Do you want to do that form?
Yeah.